So someone wanted to know about how we should do the ophthalmologic screening for the anti-TB meds. And the short answer is there is no validated screening strategy for the tuberculosis medicines because the finding is not dose dependent, dose responsive. There's no dose gradient. It can happen at any time. There's just risk assessment. So the risk goes up the higher the dose and the longer you're on it, and whether you have concomitant renal failure or not. So 15 mg per kg of ethambutol, you have about a 1% risk of having vision loss from this drug. Once you start getting to 25 mg per kg, you're talking about a 5% risk. And if you're at 35 mg per kg of ethambutol, you probably 15% chance of having your vision loss. So the current recommendation is to have somebody check the person's vision every month. Now, it doesn't have to be an ophthalmologist, because as opposed to the responsive dose gradient toxicities like hydroxychloroquine, or patients who are on medicines for a long time where the cumulative dose is what matters, in ethambutol toxicity, it's not really a cumulative dose thing, and they're not usually on it for very long. So the toxicity occurs relatively quickly. It's not going to happen 5 years from now. It's like going to happen 5 months from now or 5 weeks from now. And so that's why this screening strategy is to check their vision, make sure they're 20/20, and you can do that with a near card, and we just give patients a near card, and some assessment of their central vision, usually Amsler grid. But there's no screening strategy. It's just check their vision, and if it goes down, stop the medicine. The other anti-TB medicine that causes vision loss is INH, isoniazid. So if they keep getting worse despite stopping the ethambutol, we would also stop the INH, the isoniazid. But almost always it's the ethambutol. It's characterized by bilateral symmetric decrease in visual acuity, a central scotoma or a cecal central scotoma on the visual field, and the nerve looks normal in the beginning because it's retrobulbar, and then you get temporal pallor and loss of the papillomacular bundle over time bilaterally. Please don't wait for the development of the temporal pallor before you stop the medicine. As soon as the person's complaining, we should stop the medicine. So on the other side, the prescribing doctors have to be thinking about, do we need the ethambutol? So do we need 1 drug therapy, 2 drug therapy, 3 drug therapy, 4 drug therapy? So you might choose just 1 drug therapy, INH, isoniazid, if they just have had an exposure. Their PPD is positive, they're a medical student, they just got exposed, their chest x-ray is clear, and they have no symptoms of pulmonary symptoms. Well, we're not going to give 4 drug therapy to that person. You probably get away with just isoniazid in that setting. However, if you're active tuberculosis, in order to prevent resistance of the organisms, we're going to have 4 drug therapy on board, and then they're going to test the sputum for sensitivities, and then we're going to think about getting rid of some of these medicines depending on those findings. This is all on infectious disease, not on you. An ophthalmologist only needs to know what medicine they're on, what dose, do you have concomitant renal failure, and how long is it going to be on them. Somebody has to check their vision, but it can be the patient or the doctor or the nurse. And if they start getting vision loss, do a field for a central cecocentral scotoma. We're going to look at their fundus, both with the fundoscopy and the OCT. And please don't wait for their nerve to turn pale before stopping the medicine. If it doesn't work, stop the INH as well. Don't stop any of these medicines without calling the primary prescribing doctor. So the anti-TB medicines, someone has to check them once a month, but it doesn't have to be an ophthalmologist.